Dear Chair, dear colleagues, my name is Elias-Leon Nolden, and my PhD thesis is about the implication of personalized medicine in maxillofacial surgery. I'm a dentist as well as a fifth-year medical student, and I'm from the Department of Oromaxillofacial Surgery and Stomatology, as well from the Department of Oral Biology here at Semmelweis University. Our team consists of my supervisors, Mihail Vasilko and Laszlo Kölisch, my SMS Alex, and my statistician Bogi. My vision is to transform maxillofacial care with tailored solutions, and my mission is to provide better clinical decisions based on research. And how can I approach my mission? Well, tailoring treatments to individual specific patient needs rather than applying a one-size-fits-all system has become the gold standard. And personalized medicine in oral maxillofacial surgery is more than targeting therapies based on genetics or biomarker profiling. It extended to creating customized so-called patient-specific implants, so implants based on our patient's unique anatomy. And this is also the core of my current research. And we already know that this shift is much part of a bigger trend. Personalized medicine and the demand of it is increasing in all fields of medicine, and maxillofacial surgery is there no exception. This brings me now to my first project, where I'm comparing patient-specific implants with the stock system in patients under TMJ-Reconstruction, and I'm using here systematic review and meta-analysis to achieve this goal. End-stage TMJ diseases impair our patients' quality of life by causing unstoppable pain, problems with diet and mastication. And this makes TMJ replacement necessary. And we already know that in just 5 years, it is expected to have 60% more of operations of TMJ replacement, which will be just 900 operations per year in the US. That's why our aim was now to investigate if the customized or the stock implant lead to better patient results. Our outcome of interest was the maximal mouth opening measured in millimeters, as well as the pain and diet measured on a visual analog scale. And our hypothesis was that the PSI is superior than the stock system in terms of rehabilitation of the stomatognatic system. We conducted our systematic search in 3 different databases. We had 42 observational studies, mainly prospective and retrospective. And as you can see on the picture, we decided to include 2 types, the biomet and the TMJ concept. These are both accepted by the FDA, and we excluded all those which were only partially replacing the joint or were extended patient-specific implants. We decided also to look at 3 different angles at our data. Once we looked at all the articles together, then also only the TUAM articles, and last but not least, we looked at the individual patient data to see potential confounder. This is our first result, the maximal mouth opening. The effect size is here the pre to post-operative change in millimeters. Each row represents a different follow-up time. On the left, you see it for PSI, and on the right for the stock system. And as you can see, both of the systems work very well. This couldn't reach a mathematical significance. However, if we look now at the mean difference between the 2 systems at the given follow-up time with positive values favoring the PSI and negative the stock system, you can see that in almost all subgroups, the PSI is superior than the stock system. However, this also couldn't reach a mathematical significance neither. Regarding our TUAM articles, we found out that also here PSI seems to have a superiority than stock system, with reaching now a mathematical significance of 6 millimeter mean difference when choosing PSI than stock after 1 year postoperative follow-up. We also found out that males seem to benefit more when choosing PSI than stock system, as well as a 10-year, at the time of operation, 10-year older patient will have a less positive change than a 10-year younger patient when having a TMJ replacement. Also, those patients with already high preoperative baseline, a high preoperative mouth opening, will have a less change of mouth opening after the operation than those who already had lower. So as a result, we can say that both of the systems work very well. However, we can see some kind of superiority for PSI, with also reaching a mathematical significance after 1 year, and only looking at the TUAM articles. Regarding our secondary outcomes, pain and diet, we had contradicting results with favoring stock at the immediate postoperative pain reduction and a long-term diet function. Our biggest strength is that we have the most comprehensive study to date with very precise results due to narrow follow-up time, and we use separate analysis for two-arm and individual patient data. Our biggest limitation is that due to our nature of our included study that we had observational studies with high heterogeneity and that rehabilitation protocols were not standardized. The biggest implication for practice is that surgeons should tailor implant selection based on patient needs, meaning if we have patients with low mouth opening, we should choose PSI, and those where we want to address pain and cost-conscious cases, we should choose stock. The biggest implication for research is more transparent and standardized diagnosis as well as rehabilitation protocols. And our manuscript got accepted in the International Journal of Oral and Maxillofacial Surgery, and we could also present our results on the annually patient-specific congress in Bruges this year. Regarding our second project, where we're also comparing patient-specific implants with handmade implants in patients with cranioplasty, and also here we are using a systematic review meta-analysis to achieve this goal. Cranioplasty is considered as a standard procedure in maxillofacial and neurosurgery. However, it comes with quite high complication rates compared to other routine surgeries. And also here we can choose between the patient-specific implant and the hand implant, and as you can already see on the picture, the non-customized implant often shows imprecise fitting and then also come with a low aesthetic satisfactory. So that's why our aim was here to investigate if the PSI or the handmade implant lead to better patient results. Our outcomes of interest were the safety measured by the prevalence of postoperative complications. The most important is here the implant removal. Then also the aesthetics measured on the visual analog scale, and surgery time and length of hospitalization. And our hypothesis was also here that the PSI is superior than the handmade implants. We could include 131 articles, mainly observational studies. And also it's important to know that we have important predictors, as not every material, there are different materials and not every of those can be customized and also handmade. For example, PEEK always comes a customized material, while an autograft obviously only can be handmade and not customized fully. Also here we wanted to look at our data from three different angles. Once as all the two-arm articles, then all the articles together, and also the individual patient data where we're still working on the analysis. Here you are looking at our most important outcome, the implant removal. You're looking here at the odds ratio on the top for titanium between PSI and handmade titanium implants. And choosing a PSI titanium implant can guarantee you 66% less odds of getting it removed when choosing PSI instead of handmade. The same for PMMA, where you can expect to have 44% less odds of getting your implant removed when choosing the PSI. This table shows the proportions of all the studies together, also for the outcome of implant removal. At the top you see those ones ordered with the lowest proportion, and at the bottom those with the highest. And as you see in the first column, you can see that regardless of material, the PSI comes with lower implant removal rates than those which were hand molded. Regarding our second outcome, the operation time in minutes, also here we can see regardless of material, those which were customized lead to less operation time and faster, more efficient operations than those hand molded. To interpret our results, as I said, lower implant removal rates with PSI. These couldn't reach a mathematical significance at this point. We also found out that surgery times with PSI are faster, and regardless, or like when we look at the materials, Hydrox Apatite seems to have the best outcome from all when customized. And overall, regardless of the material, PSI seems to be better. This is our current progress, and we also hope here to present our results next year on the patient-specific congress. So in summary, both of my projects are investigating in patient-specific implants and personalized medicine in maxillofacial surgery. And I would like to thank you with my favorite quote from Eugen Roth, and please allow me to say it in my native language. Ein Mensch fühlt oft sich wie verwandelt, sobald man menschlich ihn behandelt. Thank you for your attention.
Why do you think that by 2030 we will have so much more need for replacement of TMJ?
Well, to be honest, I said 900 operations per year in the US. That's obviously an increase to the current numbers. However, this is, compared to other routine surgeries, quite low numbers. However, the demand is increasing once due to higher prevalence. So joints in general in the body wear out over time due to cyclic loading. And also, since we have more and more better patient outcomes due to more efficient, faster, and safer surgeries, and then we have also better patient outcomes. So the overall demand will increase by itself then. So, yeah.
Yes, but as a dentist, I was wondering, why would there be a higher need? What could be the reason?
I mean, the TMJ replacement is kind of the last thing we can do with the TMJ. So we only apply these kind of surgeries if all conservative treatments have failed before. So this is basically the last option we have, for example, in severe ankylotic patients where patient can basically just not open their mouth anymore, having like mouth opening less than 5 millimeters, or chronic pain tendencies where whole face is affected by it. So only for these very selected and indicated patients we will do that. However, the overall demand will nevertheless still increase since it's becoming more and more better, these kind of surgeries, and more accepted then also.
Yes, thank you very much. My question is for the first project. Did the patients receive any kind of rehabilitation or medication or physiotherapy that would also help in the healing process?
Well, physiotherapy in general is one of the first approaches when coming to TMJ problems. However, if we decide to do a TMJ replacement, the patients have to be followed up in a rehabilitation protocol. This means mostly physiotherapy, different exercises to increase mouth opening, and
But in your studies included, could you sort of standardize these studies according to this, or did you look into it? Because if one of the articles or one of the clinical studies had physiotherapy in I don't know what kind of frequency and the other didn't, it's difficult to compare, right?
Definitely agree with you. Also, it depends very much on the patient compliance. So if they actually do the physiotherapy in the end. But there was definitely, this is one of our reasons, or like an explanation for our heterogeneity, because they were not standardized, or like they were at least not transcript reported. So basically sometimes we just didn't know if they were compliant to the rehabilitation protocol, if there was one, and how it was.
There were 3 outcomes you looked at: mouth opening, pain, and diet. You didn't talk much about pain and diet. Can you just elaborate on, firstly, how you measured those?
We measured it on a visual analog scale, so a scale from 0 to 10, and patients could subjectively tell us after the operation and before the operation how they feel, meaning 10 is basically the worst pain you can imagine, while on diet scale 10 would mean an absolute improvement, like you can eat whatever you want. And these were our secondary outcomes. We also here reported the mean difference between the 2 systems. And as you can see, there are slightly changes. So also here, in both cases, with both implants, pain can be decreased and diet can be increased. However, the question is now, of course, for example, in the first row, a mean difference of 1.23 millimeters on the visual analog scale is clinically relevant? Probably not. But it is important to notice that both of them work very well. So, yeah.
No, thank you for that. And so let's just focus a bit on pain. So what's the best way to assess pain? So you've used a numerical rating scale. Visual analog scale is 0 to 100. It's a 10 centimetre line. Numerical rating is 0 to 10, so it's got 11 points. And you can only pick a point between 0, 1, 2, 3, up to 10. So you've used a numerical rating scale. Is that the best way to assess pain?
I would say it's the most efficient way, since in our studies, patients were followed up not only at one time point, like over more time points. And there they always needed to point out on which pain scale they are, if they're improved or not. For sure, it's not the most accurate method to measure pain, but since it's a subjectively feeling, it's quite hard also to find their better methods, which then also not increase, costs and decrease efficiency when it comes to seeing those patients and doing the follow-up of them. So, to answer your question, no, probably it's not the best option, not the most accurate one, but it's sufficient enough to see if a patient is improving or not.
No, thanks for that, and that's what I was looking for. So I'm really interested in the diet question, because that's probably one of the patient-reported outcomes that is most important for a patient. You know, whether or not they can eat the foods that they want to eat. So I've seen patients with bony ankylosis and they have 2 millimetres opening and they don't complain of any functional impairment. It's quite incredible. So can you just tell me, just with your findings around the diet, did you notice anything that was quite unusual with some of the findings where, in fact, there wasn't an association, for example, between diet scores and mouth opening or pain? Were there associations or not between those three variables?
Well, we couldn't look directly at the if we look at that, we expect the largest mouth opening happen over a long time of period. And now if we look, for example, at the diet where we have the longest follow-up after 2 years favoring here the stock system, it is a bit contradicting. And this is also kind of our statement regarding these both subjectively assessed secondary outcomes, that they are contradicting, and as you said, they very much vary from patient to patient. So that's why it's also hard to see here some kind of bias-free connection between them.
Thanks. I hope you don't think this is an interrogation, but it's a pet interest of mine. With mouth opening, so you found in males there was a greater increase in interincisal opening compared to females. Why do you think that is? Is it purely an anatomical finding in that males tend to have bigger jaws, and so when you open, you're measuring at the far end of the jaw that you might have the same rotational angle, but you're actually measuring out here, so you might actually just have an increase? Or do you think there's another reason for the difference between males and females?
Thank you. First of all, regardless of males or females, in both systems, when choosing custom, the mouth opening could be increased. However, we only could reach the mathematical significance here for males and not for females. This can have a lot of different explanations. Like from a clinical point of view, we could say, or we know that female TMJ pathologies might be related to more systematic diseases, such as rheumatoid arthritis. And those kind of systematic diseases then also will influence more the healing capacities. While on males, we see like more trauma cases or ankylosis and tumor etiologies. So this could be an explanation. But also on the other hand, since it couldn't reach a mathematical significance, it could be random too. So we don't know then basically also.
I have one question regarding your first project, which is about the individual solutions, if I got it right. So what do you think, how many experience do you need to really be able to produce a solution that's accepted by the patient, you're sufficient with it? So how many, what's the learning curve behind to produce an individual solution? How many experience do you need to be able to do so? Mm-hmm.
Thank you for your question. When we talk about patient-specific implants, for example, in TMJ replacement, not just the implant itself will be customized, also we will get so-called cutting tools, which we can basically apply on the patient's anatomy, where we can perfectly do the cutting, the osteotomy, and then just insert based on that the implant. So yes, it makes surgeries, or it can make, or should make surgeries easier. However, also, since everything is guided then, this kind of thinking out of the box, it's getting more difficult then, because maybe we can say, okay, when younger surgeons apply those techniques and are more used and they trust more these kind of tools, let's say if something happens that the planning was not sufficient and it's not fitting, and you have to deal with that, this can bring you then in a big problem, because you're not used to like think out of the box and use it kind of, or adapt it kind of yourself. So I would say it makes things easier. However,
still you have to be creative.
Yeah. You might need always to adapt in situations where then things are not fitting. But yes, it should make things easier. Like as we saw, for example, in cranioplasty, where we could see also the surgery time gets more efficient. This is the reason why we have like more straightforward protocol where we have to cut and what we have to do.
Yeah. Thank you.
Thank you.
When you are talking about stock implants, are there several different types which you can choose for the patient, or there is just one standard size and that's it? Or so does it require a pre-planning already and the stock is somewhat adapted already, or it's just the same for everyone? And those, especially the condyle of the mandible can be changed differently in horizontal position as well. So when we are talking about stock implant, how they are placed during the planning, what you consider?
Thank you very much. The stock implant itself and TMJ replacement also comes in different sizes. For example, since it consists of two parts, the condyle and the fossa part, also those two parts can be fully not individualized, but there are different sizes we can choose basically. However, those most of the time then the surgeon looks at the medical imaging before the operation, already has a tendency of which sizes might fit or which not. Different sizes comes to the OR, and then intraoperatively we can choose and see which is fitting. So yes, there is some kind of individual approach when choosing also stock, but it's not fully customized and not then also fully adapted, as you said, for some cases with more unique anatomy. Also, this was kind of a bias in our study, since surgeons tend to use customized implants for those cases which have a much more complex anatomy than those ones who don't have it.
I would have a question regarding the implication of this PSI technology, because I'm interested in how the surgeons are involved in the planning phase. So are there companies who are doing the planning and the manufacturing these implants from the beginning to the end after the CT imaging, or how does it work?
Thank you for your question. Probably it also depends from country to country again. However, usually the workflow is kind of that we do some medical imaging, mainly CT. Then there are certain, depending on which factory you are working together with, certain programs where you can design your implant. This is mostly done by the surgeon, since he is also the one who has to insert it later. This will be then sent to the company, and from there on the company takes over, produces the implants, manufactures the guides, the cutting guides and everything, and then sends it to the hospital bag. And sometimes we have bioengineers also assisting in these, or kind of doing supervision in these surgeries and helping the surgeon then. But most of the time the surgeon itself has to design it.
Can all of the cases be solved with both a stock and both a custom implant?
Thank you for your question. No, not all of the cases are eligible for both. As I said, there are very selective cases where we just simply cannot use the stock system, since most probably due to complex anatomy cases. And yeah, so that's not always eligible.
And did you exclude these cases from your study? So those that only can be solved with the custom, because there's no meaning in checking the difference where there cannot be difference.
Thank you. Well, we tried to exclude studies where those complex cases were present, such as, for example, we excluded those called extended patient-specific implants, where not only the actual joint got replaced, but also, for example, partially parts of the mandibula and large cancer operations, for example. Those were excluded. However, we have to say that the patient selection and the allocation of PSI or stock was not very transparent, reported in the studies. For example, surgeons tend to use new methods which are more close related to new physiological standards to reach more better patient outcomes. And sometimes it was just a personal preference of what the surgeon liked or not. So there was not really a standardized allocation and selection reported.
Were you able to make subgroups in the follow-up time of the recalls?
We did, yeah. I can show you, like for the secondary outcomes, you have already seen it. But also for the first outcome, it was for us very important to have the most narrowest follow-up time subgrouping as possible to see potential deviation between the two systems. And as you can see here in the columns, each row represents a different follow-up time. Of course, the same patient data is repeating here, since most of the time patient got invited for multiple follow-up times, half a year, 1 year, 2 years, 5 years after surgery. And this is also what we then included.